I'm very happy to be here on the front of you because this training was planned in 2020 and because of COVID, in fact, nothing happened. But now, with the help of EUROTOX and EUTOX, this is fact. So, this is the fourth EUROTOX course that we organized in Bulgaria, and the first one was in 1999 in the sea coast, and with some of the colleagues here, they are here now, we still work, and they are here now in this room. Now I would like to present the colleague on the front of you, Professor Corrado Gali. He will say some words on the name of EUROTOX. Professor Karolina Ljubomirova, she is Vice Rector of Medical University of Sofia. Professor Thomas Hartung from Baltimore University.
Johns Hopkins.
Oh, Johns Hopkins, oh, sorry. And Associate Professor Theodor Panev from National Center Public Health and Analyses. And also here is Associate Professor Iliana Najdenova from Technical University of Sofia. Because this training is in collaboration with EUROTOX, EUTOX, also with the support of Technical University. Here this perfect whole is under the Technical University, also National Center of Public Health and Analysis. Thank you. So now I give the floor to Professor Ljubomirova.
Dear Professor Georgieva, dear professors, dear colleagues and participants, on behalf of the Rector of the Medical University Sofia, it is my great pleasure to welcome all of you here in Bulgaria on the next, the new EUROTOX course organized by the Bulgarian Toxicology Society. Bulgaria has a long tradition in academic training and research in toxicology. And the staff and the faculty here, consisting of professors from Bulgaria and EUROTOX and abroad, guarantee that this course will be successful as well, because we hope that we will be able to contribute to your education in toxicology, and you will be able then to implement this knowledge into the different fields of toxicology you work in. The first course I participated, the first EUROTOX course, which Professor Georgieva mentioned in 1999, was the first course I participated as a PhD student, and then I fell in love in toxicology. And this love lasts already almost 25 years, and I'm very happy that the colleagues which I met there, Professor Georgieva, Professor Kandeva, and Professor Panev and many others, are still working very actively in toxicology, and we work very well together as well. So the next course, EUROTOX courses in 2006, in 2010, were very successful as well. So I hope that each one of you will find the necessary, what he needs for his education, and I wish success of this course and many new friendships and also new opportunities and ideas for cooperation. Thank you.
Now, please, Associate Professor Theodor Panev from the National Center of Public Health and Analysis, Ministry of Health.
Dear professors, lecturers and guides, dear participation, dear colleagues, allow me to welcome in Bulgarian and to the training in advanced toxicology.
Now, please, Professor Gali, say some words on behalf of EUROTOX.
Good morning, everybody. Just a few words as a past president of EUROTOX. So we decided, to organize some courses throughout Europe, and so the idea was to have some basic courses and some specialized courses like this one. The idea was try to give some theoretical approach to the risk assessment or risk analysis, as we can say, and then to have the specialized courses concerning some case studies, practical case studies. But, this is the most difficult thing, the case studies, because you need people who is, already some activity in the field, so is already inside in the exercise, because as I try to explain theoretically in my slides, what you have to do is just that you have to collect data, you collect the scientific information, but then you have to put yourself in the game, because it's your experience, your duty that has to find out some what they call safe dose for the consumers and the public. Now, I think that EUROTOX did very well during these years, even if we had to stop, for the pandemic some time. But the idea is to continue in a regular way to organize these courses. But the idea is to go a little bit further. to organize some courses with just case studies, because that is the most important part. Okay, I think that, I will wait until my turn.
Thank you, Professor Gali. Professor Hartung, would you like to say something for us? To us?
Yeah, thanks a lot for having me. Arnold Lehmann was the head of the Food and Drug Administration in the US in the 50s, and he's well known for one quote, which is, "You too can become a toxicologist in 2 easy lessons, each of them 10 years." I have done these 2 lessons. I learned toxicology over 20 years. My 3rd lesson, the next 10 years, was to learn why it does not work. And now in my 4th lesson, I'm about to try to change how we are doing toxicology. And I'm trying to show you today in my presentation where I see at the moment disruptive technologies allowing us to do things differently. And I think this course will be good for 2 or 3 years of learning toxicology. Enjoy.
Thank you, Professor. Now I will give the floor to the Associate Professor Ilyana Najdenova. We work together in some projects and very good collaboration. So thank you, Ilyana, for being here, everybody, to give us the opportunity to use this perfect environment. The floor is yours.
Dear ladies and gentlemen, good morning. I would like to take the chance to welcome you at Sofia, Bulgaria, and also at Technical University of Sofia. On behalf of the managing authority, I would like to welcome you also here in our brand new National Center for Mechatronics and Clean Technology. We are involved in numerous projects, different scientific groups from the university. I have the chance and the great pleasure to collaborate with our colleagues from the group of Professor Zveta Georgieva and also with Margi Kondova and other colleagues from the Ministry of Health. I would like to give you the chance to use the time as much as possible to gain knowledge and understanding about the topics that are most interesting for you. Share interests, share your work, and keep this communication for the future. I'm sure that for all of us as scientists, as much as for me, some events like this bring a lot in our present and future work. So enjoy the meeting and take your time with the pleasure I will have during the entire event's time. So let's start the meeting.
Thank you, Ileana. Now it's time for work.
I was asked, as I said, to give a couple of lectures, one more general and one more applied. As far as the general, I started with, just to remind you the risk analysis paradigm. You see that in the risk analysis paradigm, then we have 3 steps: the risk assessment, management, and communication. That's something that you will listen later. And there are 4 sub-chapters concerning the hazard identification, hazard assessment, or dose response, it depends what you call it. And then, together, the hazard and the exposure, they will, characterize the risk. So it seems to be very easy, but I heard that the first course was in '99, and I tell you that, the terminology didn't change very much, because, this model, this paradigm has been set up by the WHO in the 80s. So 99, something was already used. Now, if you put together all this information, then you have to work on what is called line of evidences. What are the line of evidences? The line of evidences are something that are in the guidelines of the weight of evidence. So line of evidence are something that are coming from your experience. So then you have to collect the scientific data everywhere, publish, unpublish, whatever you can find it. And then, so you have to build up a wall with all the information. You see that how many they are. So that's why you have to have, a quite big experience, because you have to be a toxicologist, of course, basically. But then you have to have some experience in the, what are the branches of the toxicology. Because we will see that, you have to know something about genotoxicity, the developmental toxicity, cancerogenicity, the acne, and whatever. And then, so at the end, what you have to find is just, to proceed to get information that are coming from different sources, like, we use nowadays this IUTOX approach. The next one, please. And then, so we have to put together, some new approach methodology, and among all the new approach methodology, we have in vitro, we have in ex vivo, and we have, different chemical, and in the silico, with the cross. So then, nowadays, a lot of help you can get from, especially the silicon, the chemical, the cross, but be careful, because, don't consider all the information coming from these models to be a kind of ultimate message, because that is something that you have to put aside, and then you have to add this information to other information, because the silico and the chemical and the reader cross are not the final response to what you need. It's something, again, that is something that you would have to use as a line of evidence in the weight of evidence approach. Now, so you have to put everything together. You see that now message is that you have to try to combine all the information, in vitro, in vivo, and try to extrapolate everything. So when you have your whole, then you have to use your brain. That's the problem, because you have to insert all the information in your brain, and then, I mean, you yourself, you have to weight all the line of evidence. What do you mean weight the line of evidence? So you have to put together the information and try to arrive at the end to define what are called the point of departure. The point of departures are, you know, the end of your hazard assessment. So at the end of your hazard assessment, you have to define, to determine from all the information that you got previously, you have to define what are called the point of departures. So the point of departures are mainly, I mean, in the past was no L, and now is the benchmark dose that is more fashionable, if you want. And then, so that is what, again, is point of departure, because that is, you know, the end of your exercise in the hazard assessment. And, you know, is the end of your digestion of all the data that you have collected, and then you have to define this dose, which is the highest dose, which will not produce any effect, adverse, harm, toxic, whatever. So it's the end of your dose response curve. What is the difference between you know, the NOEL and the benchmark dose? No, it's not very much. It's just that I mean, the NOEL is something that I mean, you define at the beginning of your experiment, because I mean, you define some doses, and then at the end of the experiment, you look at your results, and at a certain point, you see that this is the lowest, the highest dose without effect, and then this is the no observed effect level, adverse effect level. But what is the difference with the benchmark dose? The difference is just very easy to understand, because you know, the benchmark dose is something that I mean, you calculate on all the dose response curve. So it's not just the point that I mean, you defined at the beginning of your experiment. Then next step, what is just I mean, to understand if I mean, this point of departures, you know, the NOEL and the benchmark dose can be used to calculate the health-based guidance values. So the doses which are you know, safe for, I mean, for yourself, for all the population, for, you know, all the consumers, and for the people working in our environment. And you know, the solution is very easy, because to the NOEL or benchmark dose, I mean, you apply a safety factor of 10, which is, you know, that's something that you use from animal to a single individual. But since we are, you know, quite different concerning the enzymes and the genes that we can express in protein and enzyme, so then we apply another safety factor, because we reduce other 10 times, you know, what. Remember, what was already, because of the precaution in the exercise. That's why I point out that, I mean, we are starting from a dose which didn't produce any toxic effect. So, and then we divide it by 10 and further by 10 to what? I mean, to arrive to, these are examples of, you know, the health-based guidance values, which, I mean, in the next slide, we see that, you know, are, they can be different between, that's something that we will analyze in the second part of our presentation, because we have to differentiate in the hazard assessment, that is quite important, between non-DNA reactive carcinogen and the DNA reactive carcinogens. So you will learn that the non-DNA reactive carcinogens are equivalent to the toxic chemicals. So why? Because I mean, with the non-DNA reactive, we admit a threshold, which is very, very important, because if we use a threshold, I mean, we can start from doses and then we can calculate the safe or some safe dose. But I mean, if we are dealing with not the DNA reactive carcinogen, we have some tools to use, like the marginal exposure, the threshold toxicological concern. But I mean, we are not talking about safe dose. We are talking about a kind of priority. So when we use the marginal exposure TTC, we are dealing with the level of concern. So you understand the difference. Here we have a very threshold doses. Here we can just trace a list and say that on the top is the most concerned chemical, because we have to find out some more information on that. Then, you know, the next step is should be easier, because the next step, I mean, you have to deal with the exposure. And, you know, the exposure is something that can appear easy. But then when you start, I mean, to calculate or to measure the dose of toxicant, then you have to look for the individual. Then there are some subgroup of population very sensitive, so that they are different from, you know, an individual. And then you have to consider the possibility that, I mean, you can ingest, you can be exposed to a chemical maybe one day, a month, one day a year, or maybe every day. So you see how it's complicated, the concept of the exposure. Then, I mean, the last step is what? Is that, I mean, when you have defined your health-based guidance values, and then you have defined your exposure, then, of course, I mean, the health-based guidance value should be much higher than the exposure. That's the end of the story. You see, the risk assessment is something that's very easy. The problem is what? The problem is that you have to know very well how, I mean, to digest, I mean, your information. So, I mean, arriving to a hazard identification, hazard assessment, and then you have to have, you know, good data concerning the exposure. And that's why, I mean, the collaboration with chemists and toxicologists is so important, because you see that one of the two parameters which are quite very important is the exposure. And then we have to ask to our colleagues, chemists, I mean, to help us to give some information. Information maybe not only on the material that you are going to test. Next, please. But I mean, you know, here we start with I mean, some very, very simple questions, and there are some simple questions. The first one is, I mean, what is the material? To what we are exposed to? So, referring to our chemist friends, I mean, we have to, you know, ask them not only, I mean, to give you some information concerning the material in general. Because I mean, your chemist will come to you and say, okay, that is 97% of your chemical. And then, I mean, the toxicologists are now to ask, but what is the other 3%? Because, you know, sometimes, we can go to the next slide, I mean, what is important is the impurity presence. So, because sometimes, maybe for example, azodyes, I mean, the carcinogenicity of some azodyes was due just to 2% of one impurity. So that's why you understand it's important to know very, very well what is the you know, percentage of the components of your material. And you see that purity is one, and then toxicology should know something also on the physical-chemical properties, because I mean, it's very easy as far as the pH. But I mean, if you know if your chemicals is a lipophilic compound, then I mean, a flag should come to your brain, because lipophilic chemicals can accumulate. And then maybe if it's not active in a very low concentration, at a certain point when the concentration coming up, then at a certain point those concentrations can be the reason of the toxicity. And what about the vapor pressure? I mean, if there is a high vapor pressure, then your chemical can be inhaled, can enter in the environment, and then so you can breathe. And then, you know, we know that the lungs are really, you know, very sensitive to chemicals, not only locally, I mean, in the alveoli, but also because the lungs can transfer, I mean, your chemical to the blood. And we know that, you know, the problem is, or the toxicity is, apart from the local toxicity, is when your chemical is in the blood. Because if it's in the blood, it can reach different tissues, so it can cause potential toxicity. So, the last bullet is, of course, what we need, what we already discussed concerning the analysis and how important to have a good analytical data. Next one is, you know, the next question is, again, very easy. I mean, well, and then, you know, very quick slide that you know very well, the next one. So then we have to differentiate, I mean, what is the interaction with the target and where the toxic effect is. Because, I mean, you have to know the tissue where the toxicity is expressed. Because, you know, depending on the tissue, then you can have a different metabolism and you can have a different properties. So then you have to know not only how, I mean, your chemical will enter in your body and then how it can be metabolized and then how it can be distributed, but then what is the mechanism of toxicity, because that is something which is important. Maybe not only because, I mean, you know what the mechanism of toxicity in an animal, but because you have to be able, then we would have a kind of example, to understand if you can extrapolate the mode of action from animal to humans, because that is the most important part. Because, I mean, in your hazard assessment, I mean, you study the mode of action. In the risk assessment, then you have to understand if what you learn in the hazard assessment can be transferred to the humans, you know, the human relevance. That's something that should be always at the end of this path. Because, I mean, what is quite important is to understand if what you got from in silico, across, in vivo, ex vivo, and so on, does have some importance concerning the human relevance. Otherwise, I mean, your job doesn't have any meaning. In the next one, we have another question, the causality. Causality, because sometimes you can, they say, associate, you know, the treatment with an effect. But then that is not enough, because if you see maybe something happen, that can be, you know, that derived from, I don't know, from the, you know, some saturation of enzymes, pathway, or so on. So you have to understand if, I mean, really, I mean, the treatment caused that effect. So that is the most important part. And so the causality, remember, that is the basic part of your path to reach the risk assessment. Then another question that I mean you can have is that I mean, how can I understand the causality? And so you have a lot of tools. See that you have, you know, to study the mode of action, and nowadays we have the adverse outcome pathway, so then you start from the molecular events and then you go up, I mean, to more complex mechanism. The only problem that the AOP, the adverse outcome pathway, that you have to add some information concerning the kinetic, because in the AOP concept is not present the part of the kinetic, and not is a quantitative, it's just a qualitative. So that you have to add your experience to respond to some question. The last question is who is the center? Because I mean, we have this dose response curve, but it's not a dose is a response, it's a frequency. So then we have many times that, you know, increasing the dose, we have some response, that increasing the dose, we have that the average of the population will respond. But then sometimes, if we increase the dose, we do not have an increase of the response, because there are some individuals which are less sensitive. And then that's why they have maybe more enzymes to detoxificate your chemicals. So at the end, so you see that the concept of the dose response curve, it doesn't work when you have you know, different sensitivity of the population. In the next slide, I mean, you see the last and the basic question. So then we have to have a dose response curve, because otherwise, I mean, causality is not present. Because so when I say dose response curve, it's something that is very easy to understand. So then, if, of course, I mean, we have every time that we increase the quantity, then we have an increase of the biological response until a certain point when you get you know, some adverse effect, maybe not immediately toxic. And then, so when you build up your dose response curve, I mean, you understand that there is a threshold, you know, because below that dose there is no any toxicity or adverse effect, but above that dose you can get a toxic effect. That is, you know, very, very important. It's crucial for the hazard assessment, because you know, in this case, I mean, you arrive, I mean, to define a kind of point of departure, which is you know, the lowest dose of the toxic dose. Then, I mean, to refine the concept, it's different than we study pharmacology, because when we study pharmacology, we need, I mean, to understand if our drug is active, that we have an increase of the biological response. Then, when we deal with toxicology, then we start from the opposite. We start from to define the toxic dose, so then we have to build up a dose response as far as the toxicity, and then toxicity is, you know, in this case, the example is the induction of liver enzyme. But what we need for our hazard assessment is just to have another dose response curve, where, you know, backwards. So then we have to define our dose response curve, you know, backwards, as I said, because then our aim is just to define a point of departure. That is, again, I mean, what is basic for our hazard assessment. Otherwise, I mean, we have to start again from the beginning. That's the problem. So start again from the beginning, then you go back to your data, and then you try to interpret them, and then to put together them, and so able to arrive to define, you know, this point of departure. Because without point of departure, so you do not arrive to anything. Now, concerning you know, some examples, then so we will proceed. Here you see that I mean, what our aim was to calculate the margin of safety and the distance between toxic dose and the point of departure, because that is most important, really important to understand the potency of your the toxicity. Because of course, less distance you have here, more potent is your toxic. Now let's see very quickly, I mean, to go through some of the parameters that on which you have to concentrate. So concentration of xenobiotics, of course, I mean, you have you should know the amount to which you are exposed, and but the amount to which you are exposed depends, you see, from many parameters, like the route of absorption, for instance, and then it has to be clear what, I mean, is the difference between a cutaneous application or an intravenous, of course, because one of the tricks when you start with, I mean, because the LD50 is one of the parameters where you can get more information. It's very easy. Even if forget the lethal dose 50 to calculate your point of departure, of course. But I mean, this is the beginning, and you have to have sometime a table on which you put all the LD50. And so one of the tricks is that I mean, the LD50 intravenous should be much lower, of course, than in the oral percutaneous, because if you inject intravenously one chemical, the chemical will straight arrive to the target and produce toxicity. But I mean, if you administer orally, then of course it has to pass through the gut barrier or the lung barrier, sorry, the gut barrier, and then have to enter in the blood. You see how the curves, the pharmacokinetic is quite different on the different sources. Next parameter is, the dose and absorption. And that's again, I'm sorry if I'm giving you some very simple information, but that is the path that you have to follow. Because I know that you know very well all this information, but it's not the information which is important, it's the mechanism that you have to follow. Because after the absorption, then you have to understand, I mean, the mechanism of absorption. Because, I mean, sometimes if you have for instance, the P protein, and the P protein will try to wash out your chemical from the body. And then it's something that you have to understand. Because sometimes toxicity is less, or maybe in the pharmacological field, I mean, the presence of this protein can reduce the activity of a drug. Because this protein will try to help your chemical to exit from the liver, from the body, and then you will reduce the pharmacological activity. For toxicity, maybe, I mean, to have this protein helping you to reduce toxicity, that would be a good idea. Next slide, liposolubility. We know very well what is the correlation between, the toxicity and then solubility, because the toxicity is increasing with the log P of the chemical. But I mean, let me spend a little time on this slide, which is something that I like very much, because in this slide you have the sum of the message for the hazard assessment. Because if you have lipophilic chemical, or maybe alkylating agent, lipophilic chemical, which have a very high reactivity. High reactivity because they are maybe oxygen radicals, or they are some electrophilic agents, very strong electrophilic agents. Electrophilic agents, they share some of the electron of the molecule with other electrons which can absorb this energy. And usually, the oxygen and nitrogen of the big macromolecule, they have some free space for the electron of the electrophilic chemical. So that very easily, the electrophilic chemical can react with the oxygen and nitrogen on the micromolecule. But when I say macromolecule, I mean, we can speak about DNA and RNA or protein. You see that there is a big difference between the two binding. So as far as DNA, we know that, we can produce some genotoxicity. But what I wanted to underline is, the binding of some electrophilic agent with protein, because that is the basis of some epigenetic carcinogens. So the basis of some epigenetic carcinogen is why? Because this binding of some chemical can produce some complex which are very active and can maybe produce necrosis in some tissue. And when you say necrosis, okay, so cells are dying, that's a problem, because if the cells are dying by necrosis, not the other death, the apoptosis, So they can produce a phenomenon which will last for a long period of time. So the inflammation, you say, okay, inflammation is something that can be reconstituted. But then during the inflammation, you can have, that your body will react in a very complicated way, because cells start to replicate very quickly, and then when cells replicate very quickly, it's dangerous, because if you have a natural genotoxic effect, then this natural genotoxic effect can be replicated, fixed, and become the initiation of a cancer. You see the difference between the epigenetic and genotoxic carcinogen is very complicated, because nowadays we know very well, what is the situation of genotoxic carcinogen. A chemical can produce a genotoxic effect, and then the potential, to incur in some carcinogenicity is there, but it's not sure, because you have to repair, the cells can die, and so on. But if you have epigenetic, the significance is quite hidden, because you don't know very well, what is the origin of epigenetic carcinogen. So you know that some induction of receptors can do something to start to mitotic activity is something quite good. Is the long duration of the phenomenon that might create a problem. In the next slide, we have, we can go ahead, the concept of the bioaccumulation. So one example is the DDT, one insecticide that now is banned because, be careful, not because of the toxicity, because it's true that it could produce some liver tumor in rodents. But then the banning, the prohibition has been on the bioaccumulation, because the DDT and or the metabolite could induce certain concentration, what we fear very much, the endocrine effect, because the metabolite could block the androgen response, and then at the very end, you can have this androgen response, so then you have an endocrine effect. That's why this very, very efficient insecticide is being banned, not for the toxicity, but for the endocrine activity. Then, so the endocrine activity is, I heard that some of you have some experience, and the endocrine activity is in Europe now really a very important problem, because you know that we have sources, mechanisms, and critical period, can be on the next one. And then, so if we go back to the guidelines written by WHO and EFSA, you see that there are criteria. So so you have to have an adverse effect, so on intact organism. That's why you deal only with in vivo studies. That is the first thing that we have to highlight. The second step is that if something happens in vivo, then should have some endocrine mode of action. And then if you put together the adverse effect and the endocrine, then so you can define that chemical as an endocrine disruptor. But several times, some of the even agencies will forget that, to consider what? The human relevance. So that is at the beginning of the definition. And then, so it's true that maybe you have an endocrine activity. It's true that is an adverse effect. But if it's just in some flies, is not in the problem of humans, who cares? But the legislator cares, the management cares, because once one chemical is defined as endocrine disruptors, as far as there is a cutoff code, then that is, should be banned. So you cannot use any more of that chemical. And you see that, some of the assessment, they don't consider all these parameters, and especially the human elements, because we know that humans has a kind of a buffer situation concerning the physiological aspects of the hormones activity. And then for humans, some change of the hormones concentration or levels, it doesn't matter, because there are good feedback mechanisms that can reconstitute very well, the situation. And that is a problem that, will be applied, is applied nowadays, and then will ban some very, very important chemicals from our life, not having so much weight as far as the endocrine effect. Next slide. The metabolism. Then so we have. The time is running. And here the example of the insecticides, the organophosphate. Organophosphate is quite a good example, because you see that so to be activated, you have to start from a precursor with a sulfur, and then the sulfur can become an oxygen, and then there is the active molecule, not with the sulfur. With the sulfur is not so active as with the oxygen. But what is important here is that the metabolism. So because as far as the insects, you have that the metabolism very quickly can lead to oxidation, and and very, very slowly, the molecule can lose the activity, because there is a nitrolysis of one alkyl group. Then in humans, the difference is quite important, because there is first a nitrolysis of the oxidate group, and then you have the activation of the molecule. So this is a very good example where the metabolism can be the most important part of of the picture. Then the next slide, we have the last. The time of exposure. That is the best example is the developmental toxicity. So you see that the time of exposure is quite important, because we have just in the developmental toxicity, teratogenicity, we have a window which is very narrow during the development. That because at the beginning there will not be anything, and at the end you will have just morphological changes, and not anatomical changes. So the next one, reversibility. Reversibility is okay, but I see that we can go even quickly, because again we have the organophosphates, where we have the two possibilities. One is the binding of the organophosphate to the receptor, the acetylcholinesterase, and then this binding will produce a toxic effect, acute toxic effect. But we have the possibility to have the reversibility of this effect with different situation. But what is the most important part is after some hours, you cannot anymore to reconstitute your molecule or your receptor, and then the receptor is blocked, and then you have the irreversible toxicity. In this example, you'll see that you have the reversibility and the irreversibility. Now, one example of the irreversibility is just the aflatoxin, for instance. Aflatoxin is a natural molecule, and then we not open the discussion on natural or synthetic chemicals, because in this case we have a natural chemical which is one of the most toxic chemicals, that are around our life. And you see, in this case, we have different possibility because the epoxy hydrolase, after the oxidation, the formation of the epoxide, this epoxy hydroxylase can open, the epoxide, and then you see three possibilities. One, to have an addition of one hydroxyl group. The other one is the conjugation with the glutathione. That's good. The third one, is the worst because, of course, in the third case, you have a binding of DNA because we know the epoxide are quite strong alkylating agent. So then, if this metabolism is close to the nucleus, close to the DNA, so the phenomenon will happen. Okay, I think in the next slide, to underline that at the end of the hazard, we have the classification of the chemicals. The classification means that under European regulation, and also a worldwide regulation is the GHS. All the chemicals are, have a kind of printing of one number, where the chemical, we can go ahead, and then for each chemical we have a kind of recognition. You see with this H number, you see that, for instance, for acute toxicity, oral, then you have thermal and you have inhalation, but let's see the oral. Then you see that depending, you see the first row there, the pink, 5, 50, 50, 300, 300 to 2000, depending the results of the LD50, then your chemical are classified, on different numbers in relationship to the potency, to the LD50 value. Because less in the LD50 values, of course, more toxic are the chemicals. Now the last example is show you that in the regulation, European regulation, we have the classification, the different category for carcinogenic and genotoxic and developmental toxicity, irritation, for everything. Just to show you what happens for the carcinogen, you see that we have two different categories. Category 1 is known or presumed. So then, if for category 1, depending if something known, because there are some results from epidemiological observations where there is a correlation, causality between the one carcinogen and the other one. So the effect. Then at that point you have to classify category 1A. But category 1B is H340. Then you classify H341 only when you have category 2. Okay, so I think that this is the last slide. Okay, for the first presentation. I wonder if you have questions or, the load was too much to give you the possibility to ask questions, but I will be here for the next days, until tomorrow. And then if you have some doubts, please, don't hesitate to ask me something that I will be very happy to respond. No question? Okay. Let's go ahead. And now, the second part is, I would say, more applied, because in the next slide, we start, to see again our scheme, our paradigm, and then no, probably this slide is replicated in another next one. Next. Yeah, okay, this one. this is the starting point of our hazard assessment. Well, it's not true the starting point. So we arrive at a certain point when we analyzed our data, and then we had to understand if there is a kind of a cross here, if we had to go ahead with our hazard assessment with the concept of non-reactive DNA carcinogen or DNA-reactive carcinogen. That is, remember, the most important part, because there are, you will see that there are different pathways. And so if we go ahead with the next one, we start with, the first concept, then to solve the problem, to which way to go, you have to understand what is the genotoxic potential of your chemical. And to understand the genotoxic potential of your chemical, you have some tests that are in vitro at the beginning. In vitro, so you have to test your chemical, and the easy test are the Ames test, on the bacterium, on the Salmonella typhimurium, and then is, to understand if your chemical can cause some very, very minute modification of DNA on the basis, on the nucleotides. But the second test, go ahead, is the crustogenicity and allogenicity is the micronucleus test. So that you have to understand if, your chromosome can be broken down, and then maybe some part of some chromosome can go to other chromosomes, so there is a kind of interchange. Or maybe if you have a change in the number of chromosomes. You know that in a somatic cells there are 46 chromosomes, and the germinal cells you have 23, of course. So then, if something can change on the structure of chromosome, so then you can use this some tests like the micronucleus. These are the two tests that are advised by different regulation sectors, because for pesticides, from biocides, from cosmetics, from whatever, food additives. So you have to start from these two tests. If these two tests are negative, then I forgot the stage 0 because I am not convinced very much on the stage 0 myself, because it's useful. But as I said at the beginning, so you have not to use the results as an ultimate response. So you have to use the results as a complementary, information, not the last information, because these techniques, these models are still, to be, I would say, improved, because sometimes when I see some analysis of, especially read across, you see that there is a comparison of chemical structure with something that is completely different. But the importance, follow me, is not only the chemical structure, but as soon as you change the chemical structure, the tridimensional form of your molecule changes, because if atoms are, put in the same atoms in a different way, so the reactivity of your chemical can change. That's why, again, welcome to these results, but not, use these results, as ultimate message. Then going back to the genotoxicity, so then we can arrive to 3 different results: negative, so some equivocal, or positive. Now, here we have a problem to solve, because for all the other chemicals we do not have any problem, because we can proceed to the in vivo genotoxicity studies. With the cosmetics, there is a regulation in 2013 which banned the use of animals to the in vivo studies for the hazard assessment of chemical, the cosmetics, ingredient of the cosmetics. So then, as soon as you did your in vitro experiments, you have to stop there. If they are positive, then you have to throw away your chemical. And that is different from other chemicals, from other sectors, because, I mean, for other sectors, you can proceed to the in vivo. And then with, you know, the most famous in vivo are, again, the micronucleus, and the comet assay and the heterogenic mutation test. What is important now, if you have negative results in vivo, they overtake the in vitro results. You understand the importance? Because if in vitro you have positive results, and in vivo you have negative results, so then you can forget the in vitro results. That is very, very important. That doesn't happen with cosmetics, but that is the regulation. And you know, in future, we will be asked more and more, and Professor Hartung is our vehicle of the message, to use the in vitro studies at molecular level. But so far, I mean, we have the reality. So that's why then here, I mean, we decide, I mean, in which way to go. Non-genotoxic carcinogen, non-genotoxic carcinogen, because as soon as you have in vivo results, the genotoxicity in vivo results, then the potential, I mean, to be a carcinogen is high, you know, under the regulation. That's why, I mean, you have to use a different way to assess the hazard. In the next slide, so we now start with the non-genotoxic, the non-genotoxic chemical, and then but now it's easy because so with non-genotoxic we know that we can calculate you know, our thresholds. This is an example which I like very much. I mean, because is a kind of a border, I mean, between hazard and risk. And this is the, I mean, the thyroid carcinogenicity in rodents is something that nowadays is really a big pillar to consider a chemical as endocrine disruptor. And you will see from my example that again we go back to the human relevance. So is relevant for humans or not? It's true that, I mean, you have, I mean, the next slide, we have a mechanism which is as an endocrine mechanism. Because, I mean, when we administer some of this fungicide, the diethylcarbamates, we have a block, I mean, one very important enzyme in the thyroid, which produces the two quite important hormones for our body, T3 and T4. But since, I mean, we are a very, very good organism, then so a feedback mechanism is activated. So then the loss of concentration of the two hormones will stimulate, I mean, the hypothalamus, the pituitary, and to try to convince the thyroid to, I mean, reconstitute, I mean, the activity of the two enzymes, or the presence of the two enzymes. What happens now is that, I mean, we can use this scheme, which it took a lot of time for me, but I like it, that you see, we have the iodine, which from blood enter in the thyroid, and then, you know, through to the enzyme, the iodine is activated and can bind to some of the amino acid of thyroglobulin. Then it will lead to the hydrolysis of the thyroglobulin. And then, so the hydrolysis will reconstitute the two hormones in the blood. But here is the difference, because this is the hazard. So undoubtedly, we have the same mechanism also in humans. But there is a big difference because I mean, when you talk about humans, I mean, you talk about something that is physiologically very, very different, because it's true that, you know, you can block also in humans the formation of the two hormones. But now the kinetic humans is completely different, because in humans the hormones are bound to one protein in human blood, which is not present in rodent. And this binding, I mean, render the fact that you know, the decrease of the two hormones is very, very, very slow, and that it will not influence in any way, you know, the feedback mechanism that alter the signal of the feedback. So if we see the same, I spend some minutes on this because I mean, I see that is a quite important example. Then if I mean, we use the fungicides, as I told you, you have a decrease of the two hormones, but you have an increase of TSH. That is the trigger, because increasing is not, I mean, you will see the decrease of the two hormones, because it depending on the speedness of the decrease. In rodents, since the turnover of the two hormones is very, very fast, then, you know, this the situation that you have the decrease, then very, very strongly TSH is requested. I mean, to reconstitute, you remember, the feedback and to produce AT24. Then, I mean, what happens in the thyroid cells, that you have, you know, different phenomena happening, and then at the end of this phenomena you can get a neoplasia. Neoplasia because, you know, the cell replication, so then since I mean, T3 and T4 are not produced anymore, then the phenomenon of the neoplasia will start, and then cancer will appear. What is different in humans is that, I mean, we have data also on, not only on the fungicide, of course, but we have data on the phenobarbital, which has the same, exactly the same mechanism of action. And then, so we have also some autoptic observation in humans, because you know, sometimes humans, some patients have to take some thyroid stimulating agent to reconstitute the T3 and T4. And then, you know, many autoptic exams showed that, you know, in these patients there was no effect on the thyroid. That is in humans. But if we go to the mechanism of action, then we see that there is a quite important difference between rodents and humans, because in humans you have a decrease of the two hormones, but you do not have an increase of TSH. That's why, I mean, the risk, if you want, is different. I mean, again, the hazard is the same, because the mode of action is the same. But the risk is quite different, because the human relevance is completely different. But since nowadays the hazard, you know, the classification is based on the hazard assessment, then so all the agencies will consider chemical like this one as an endocrine disruptor. And that is not right, but I mean, that's the reality. Now, if we go to the DNA reactive, now the situation pretty dramatically changed, dramatically, because I mean, regulation. I mean, we have quite differences, even among, I would say, continents, because nowadays we have a different approach, because, I mean, we can go ahead. Okay, so this is the four solutions to give to the risk managers, I mean, from a scientific point of view. So there are four possibilities, and I will go through them very quickly. Alara, you know, as low as reasonably achievable. Okay, is the first one. And then, so it's not used anymore because, you know, ALARA is something that is based only on the hazard identification, no exposure, and then, so, you know, you don't know the potency of your chemicals. You know, it's been used at the beginning when okay, thank you. At the beginning when, for instance, for the dioxins in the United States, when, I mean, the head-based guidance or the whatever, I mean, the dose considered safe, I mean, were, I mean, lower than the exposure. So then they realized that they didn't have the tools, I mean, to regulate dioxins, for instance. So they use, I mean, the ALARA concept, saying to the population, so as low as possible. So that is not a good solution, of course. Now, what is better is what I mean, is used in the United States, where, I mean, it's something very, very, you know, with a lot of precaution, too much. Because what they do is just, I mean, to use the concept to extrapolate, you know, your point of departure to the cross of the axis. Meaning that you do not have a dose without a potential effect. That is the way to face the problem. So it's very, very precautionary principle. We will see that in Europe, I mean, at least in Europe, the European Food Agency, I mean, use another concept, I mean, giving us the possibility to use the margin of exposure concept. But start with the US. So then, you know, very easily, what you do, okay. What you do is to use a mathematical model to extrapolate from your experimental data. And you see that it depends what is the mathematical model, because, I mean, the doses that you can extrapolate at, I mean, the lowest doses is quite difficult. You have different order of magnitude. That's why they use the multi-stage model, I mean, to extrapolate, as I said, from the experimental data to, I mean, to the linearly to the lower doses. And then there's something that, okay, we can understand the precaution, of course, but it's not a reality. Because, I mean, our exposure is, you know, sometime at this level. And then, so you think that should be a dose-response curve. Even for genotoxic carcinogen, I tell you. Now, you know, practically, you know, this is the dose-response curve that you have already seen, and then you know, we start from the point of departure, that is the benchmark dose. I mean, lowest, I mean, because you use the lower bound confidence limit, so you, okay, that is a technical aspect. Then, I mean, what it changes is that, you know, you use the same point of departure, but the concept is that, I mean, you trace your line to the cross of the axis, as I said, not emitting any dose without effect. So then, what they call one-hit molecule meaning that, I mean, just one molecule can produce a change that can cause cancer. And then here, I mean, the idea is to measure the slope factor. The slope factor, which will mean what is the potency of your carcinogen. And you know, from the slope factor, they are able, with mathematical models, to calculate the safe dose, I mean, for the consumers as part of the oral inhalation and so on. But I mean, I just wanted to show you the concept. So here, I mean, the precaution is so strong that I mean, you would not admit that there is a dose without, I mean, you don't accept that there is a dose without an effect. I mean, everything it has an effect, even, as I said, one molecule. Now, in this example, I mean, I like to show how, I mean, even one genotoxic carcinogen can be recognized and studied through the in vitro models. I mean, here, there is something interesting because we have one solvent, the methylene chloride, which is metabolized by two different pathways. You know, the classical two, the family of cytochrome P50 or the family of the glutathione enzymes. And you see that differently from the usual concept where, the glutathione is the angle. Glutathione transferase will, cover all the improperty of our body. In this case, and also is chlorinated solvent, halogenated solvent, the glutathione transferase can, form a metabolite, this chloromethyl glutathione, which is the active metabolite, producing a binding with the DNA in the lung cells of mice. And I will explain why only in mice. But what is quite interesting is that, the kinetic of this solvent, because you see in this slide that the cancer dose was up to 4,000 ppm because the solvent was given by inhalation. Then human exposure was because they used to decaffeinate the coffee, tea, and so on. So the concentration in the cup of coffee or tea was very, very, very low. And then what is very interesting is that we have this fact that a certain concentration, the P450 system is saturated, and then it takes place, the glutathione system. And then you understand that since is the glutathione metabolite, which is the cause of the genotoxicity, of course, the concentration of this solvent is quite important, because if the concentration is below some, now it's around 800 ppm. So it's below 800 ppm, then human exposure is not a problem, because the metabolite formed is so small that we will not influence the DNA on the lung cells. But the explanation was in a way very simple, because during the next years after the banning, there were some studies showing something very clearly, that using lung cells of different species and then measuring the activity of some specific enzyme of the two families, the P450 and the glutathione. So the researchers established one thing that is quite clear, that as far as the P450, all these species has a good activity, and then you see that mouse has a very high activity, hamster as well. But hamster, so if you expose hamster, they will not get any tumor in lung. That something has to be considered. Because in rats, there was no tumors in the lung, and in humans, of course, you don't know. Then the measurement of the activity of this glutathione was the most important parameter, because you see the activity is in rat, in hamster, in human, but we see that in mouse the activity is very, very high, explaining why mouse was so sensitive to the lung tumors. And there is also another reason, because this metabolite can be formed in the cytoplasm of the cells, of the lung cells in different species, because it's formed in all the species. But in the cytoplasm, in the mice, the metabolite is formed into the nucleus. So it's very close to DNA. And then in the other species, this metabolite is destroyed, but in mice, you do not have time, to destroy the metabolite, because the metabolite is so close to the DNA, in mice that very easily can interact with the DNA, and then, you know, it starts your neoplastic effect. Now, or just, you know, again, to extrapolate, I mean, from the 4,000 ppm in mouse, what it might be the dose that might cause, but you know, the mode of action is different, that might cause lung cancer in humans. You see that we have 250,000 ppm instead of 4,000, but that is an exercise. Now, the marginal exposure is something that has been an opinion, if you want, a guidance, or whatever you would call it. But I mean, the European Food Authority, I mean, did that. So I mean, I would say tired, I mean, to use this extrapolation to low doses. I mean, there was another possibility invented, if you want, because I mean, also the safety factor of 100 is something that I mean, doesn't have some scientific approach. It's just you know, something that in 1958, I mean, Professor Trudeau, I mean, present in one of the scientific meetings, said, he stood up and said, why don't you use 100? 10, I mean, for the interspecies, 10 for intraspecies. And then, you know, the experts, you know, decided it was a good idea. And then that's why, I mean, we still use the 100 safety factor. But in this case, I mean, we use a 10,000 safety factor because we are dealing with, you know, genotoxic carcinogen. 10,000, why? Because, you know, 100 is the classical safety factor. Then you add another 10. Why? Because you know, you have the genetic difference among humans. You have the possibility that the repair systems are different. So, and then some uncertainty. To cover that uncertainty, you add another 10. Then you add another 10 because in the concept of the benchmark dose is that the benchmark dose is not a no effect level. Is a no effect level calculated on the basis of some range that you decided that is maybe 5%, 10%. So then, meaning that is the explanation of this 10, meaning that the benchmark dose is not a no effect level. Since it's no effect level, so then you apply another 10 because of the uncertainty of the calculation. That's why, I mean, when you talk about the marginal exposure, I mean, still, I mean, you start from one point of the partial defined. And then, so what you do is now, it's very simple because, I mean, you calculate the ratio between the point of exposure, the point of the partial, and the exposure. That is just an example, I mean, to show you that the ratio is 50,000. What is important is that this ratio should be more than 10,000. But again, be careful. Don't consider this as a safe dose. I mean, when we talk about genotoxic carcinogen, we have to talk about level of concern. So if in this case 50,000, meaning that we are much above 10,000, so the level of concern is low. In other cases where we have acrylamide or, you know, some furans or aflatoxin, the marginal exposure is maybe sometimes less than 100. It means that the level of concern is very high. So then you have to put a lot of effort in, you know, in those molecules where the level of concern is high. So that is the solution that I mean, is pragmatic solution if you want, because I mean, that is give you an idea of the potency or the level of concern. So then you have a priority list. So then you have to focus your attention on the chemical where, I mean, the marginal exposure is very low. That's the priority. That is, you have to prioritize your attention on those molecules with the marginal exposure low. Now, Some words on the aggregate and cumulative exposure. I have an example to show you, because when you say aggregate, means that you have one molecule, the same molecule with different route of exposure. When you say cumulative, I mean you have the same problem, but the molecules are different. So then it's a problem, because you have a kind of a mixture, and then you have to solve the problem. Nowadays, the problem with the mixture is still to be solved, because it's true that we can apply a margin for the aggregates, for the mixture, but it's not a solution, because we cannot continue to add safety factor in infinite way. Here, we have an interesting example concerning all these congeners, concerning, for instance, the dioxins and the diabates of uranes. You see that we have hundreds of congeners and different molecules. So then we have to do something, because we cannot have experimental data for all these chemicals. So then we have to find a practical solution. And the practical solution has been found by the WHO years ago, where the toxic equivalency factor. You see that here we have a series of different congeners of dioxins and the other molecules. And then from experimental data, we know that the most potent is the 2378 TCPD. And again, the same potency is from this derivative. But then if we look at the data of other congeners, we see that the potency is 1/10, 100ths, and 3,000ths. So that is the first evidence that you have to collect. Then the exposure. Of course, the exposure is, as we said several times, the most important. Then you see that the sum of the exposure is 890 picogram. But if you refer to the toxic equivalency, you see that 20 exposure, potency 1, 20 exposure. 10 exposure, potency 1/10. Then the equivalent of the potency is 1/10. And then again 70, but 1/10, 7. 130, 100, 1.3. So now if you sum now again on the basis of the potency, you see that the exposure is much less than before. And then so now we have to use this 89.5 divided by 60, these are picogram per kilo body weight. So then your real exposure concerning the calculation with this relative effect potency is 1.3 picogram per kilo body weight. So then you can apply, for instance, the marginal exposure. And then you see that in this case, you realize that, if you divide the benchmark 10 or the point of departure by the TEQ exposure, you arrive to a very, very high marginal exposure. So then it will tell you that concerning the polychlorinated agents, the mixture, using the concept, you will not have a lot of concern. Now, the last one, and then it will take the 4 last minutes I have, then is the threshold toxicological concern. This is something that is going up very much, because it's a pragmatic approach, because with the threshold toxicological concern, you define a threshold below which there is a very low probability of or toxicity or genotoxic or carcinogenic activity. Then, in principle, this is where we start. But we start from the classical hazard assessment, and then where we go through the hazard identification, hazard assessment, dose response analysis, and the exposure to characterize the risk. With the threshold toxicological concern, you cancel some of these boxes, because you need just two information. One is the chemical structure. Then we go back to the structural activity relationship. And of course the exposure. And then in this case, you don't characterize the risk, because the risk characterization is for non-genotoxic carcinogen. In this case, we can deal also with genotoxic carcinogen. And then, again, we talk about a priority list, so a level of concern, not safe dose, remember that. And then, just the last two slides, showing you that there are different thresholds. You see that we have the class 1 threshold, so I will not tell you the calculations behind this, very solid. Then class 1 is the weakest. Something that looks very similar to maybe endogenous metabolites. And then, so that's why, you have a threshold very high. Then if you go down with the complexity of the chemical structure, you see that the daily exposure is going down and down. Then, a particular aspect is for the structural alert for genotoxicity. Remember that, for this chemical, we have a very, very low threshold of concern. But just one point, that we are talking about structural alert. We are not talking about carcinogens. Because remember that the TTC is on the basis of the chemical structure. So on the basis of the chemical structure, maybe we have some structural alert, maybe some epoxide, or some group which we know that are very dangerous for our body. And then having those groups, you consider them as a potential carcinogen. They are not experimentally carcinogens. They are potentially carcinogens because in the chemical structure you have some genotoxicity structural alert. In reality, we have nowadays 3 thresholds. The class 1, class 3, and the 0.15 for the potential genotoxicity chemicals, because they are the 3 thresholds accepted by many agencies. All the others are something that on which you can reason. But for instance, class 2 has so few chemicals that is very weak. That's why all the class 2 now, all the chemicals in class 2 are now in class 3, for also for precaution. This is the last slide, because I'd like to remind you that the EUROTOX has a register for toxicologists, and you see the mechanism is very simple. So then you have to send your curriculum vitae to your national register, and you have a register national in Bulgaria. And then the committee will decide if you are a toxicologist or not. And then if the committee gives a positive response, then automatically you become an ERT, a European Registered Toxicology. So what you have to do is go to the website of EUROTOX and download the guidelines and try to compare your CV to what is requested. And then if you think that you reach a good experience on the basis of what is requested, you send it to your national committee, or maybe other committees, because there are 21 registers around Europe, and then some of them, as the Italian for instance, can accept application from different countries, but since you have your country, that will be easier. Okay, I think that I finished to tell you that you have to do that is your task in the future.